Okay.
We're on.
Okay.
All right, so welcome everybody to our afternoon session. It's Pathology, Radiology Correlations, Shadowgazing for the Glass Pusher. Thanks for being here this afternoon on a beautiful day in Vegas instead of being at the tables, and hopefully you will not risk your money spending your time with us at least, and it'll be a valuable use of your afternoon. I'm Dr. Sarah Jang. I'm a professor of pathology at the University of South Florida and a senior pathologist at Ruffalo Hooper and Associates. And this is my colleague, Dr. Dodd.
And you have nothing, no
Oh, yeah,
conflict of
we
interest?
have no disclosures.
I have no disclosures either. So my name is Leslie G. Dodd. I am a professor, and I practice cytology and surgical pathology at the University of North Carolina with an emphasis on bone and soft tissue. And I am going to lead us off. So get ready. So I'm going to talk for the first couple of minutes here. Let's see. Here's our agenda. So I'm going to talk a little bit about these two modalities as an introduction. Then Sarah's going to take over and do this central portion here, ultrasound, head, neck, and thyroid, and I'll return after her talk to finish up with some GI lesions in bone and soft tissue. So let's get started with CT. So basics of cross-sectional imaging. This technology is familiar to everyone. I think it's old-fashioned, just plain X-rays, except for X-rays on steroids. So the way the CT scan works is you get a beam, actually a very, very large beam, that goes through a patient sitting in a essentially donut, which is called a gantry, with a detector array behind them. And in the modern CT, this detector array actually moves around the patient. And the principles of X-ray in general are that attenuation. So more dense tissues like bone are going to attenuate more, and they're going to show up as a different kind of contrast on just an X-ray film. So something like this. And when the CT moves around the patient, they generate little slices about 3 millimeters thin, or even thinner in some instances. And because you're applying so much X-ray field, you can actually get well into the body here and generate these attenuation images all the way through the body. And one other thing, as we go through this presentation for CT and MRI both, you have to keep in mind that you're looking up through the patient, and ideally these are meant that you're patient-facing, right? And by convention, they're going to be on their back the way they get this scan done. So what's going to happen is, let's see with our pointer, is that you're going to have transposition of the right and left side, so liver is going to be here. And you just kind of have to remember that and get used to it. So a little bit about the history. So this technology first was developed in the 1970s, and kind of primitive. They used just a single pencil beam with very limited range of motion to do these slices through this patient. One of the first improvements was replacing the pencil beam with a fan beam, so covering more of the body per each shot, and then a rotating motion, and then finally having this whole mechanism just spiral around the patient and taking multiple continuous images. So all of these refinements kind of add up to increased volume coverage, resolution detail, and as well as markedly decreased scan times. Another component that really helped develop a modern CT scanner was the addition of a multiple array of detectors. So modern CT scans have enormous amount of detection, and there's also some variation in detector size as well. So a lot of information, again, housed in this giant donut, which is called the gantry. So if you're looking at images, the attenuation is actually expressed in something called Hounsfield units. And arbitrarily, a Hounsfield unit of 0 is assigned to water. So all of these are grayscale comparisons of an attenuation factor, which corresponds to density of the tissues, right? in CT, it collects this kind of grayscale, very large grayscale of Hounsfield units for, 0 water, all the way up into 2,000 or more units for very dense tissues like bone. Windowing in CT takes advantage of your ability to select a range of Hounsfield units to display. So for soft tissue, something like this, and it's not really very good in this modality, what you're trying to do is increase the contrast here in these different soft tissues. So you would select a very narrow window at the low end of the Hounsfield unit scale, so something like 40 to 300. And by contrast, if you want to look at a lung window, you're going to widen that up, way up, to, maybe 200 or 300, all the way up into the thousands. And it decreases the contrast here, but you get increased contrast here with a different organ with different density. And then, take that a little bit further if you want to look at bone, a bone window, you again focus the Hounsfield unit, but it's at the high end of the spectrum because bone is about maybe 2,000 or more. Costs are going to range drastically or widely, depending on a number of factors. First is the patient factor is what's being done. Is it just one single body part, or is it a scan of chest and pelvis? And also, is the patient going to get contrast? So that's going to be factored in. And then there are regional costs. So cost of living in a certain area is going to affect what a patient's going to be charged for a CT. So, in an expensive area, you're going to have to pay the personnel more. The cost of the space is going to be much more for this machinery and all other things. And then there's the issue of reimbursement. Interestingly, if Medicare is a factor in payment or not, in-network, out-of-network, outpatient, inpatient, et cetera. What are the advantages of CT? Well, the biggest advantage is speed and accuracy, and this is an excellent modality for emergent situations or life-threatening situations. This can be done within an hour, and you can get really good information when you need it for sake of time. As we all know, it can be used to direct deep biopsies. It is a modality that's very safe with individuals who might have metal implants or medical devices, and we'll talk more about that. It's usually less expensive than MRI, and patients tend to tolerate this well because it's short, and most are comfortable inside the CT scanner. What are the disadvantages? Well, the big one is radiation exposure. So in a CT scan, you get massive amounts of radiation exposure. This is not something you want to do serially or to monitor disease progress. And despite that soft tissue window, there is limited soft tissue contrast. So for that, we're going to go to MRI. Metal artifacts and image qualities, while you can image somebody with metallic implants, it does interfere with the scan quality. And then another big one, that's pregnancy concerns. So you don't want to give large amounts of ionizing radiation to a pregnant individual and expose a fetus to radiation exposure. There are artifacts. There's tons of artifacts, and we don't have time to go over all of them. Some of these are a lot of fun. And basically, you can kind of sort them into patient-based, maybe physics-based, and hardware-based, and I'll show you an example of each one one from each category. So here is a motion artifact, and it's called misregistration, and you get this blurring and streaking, and things don't align here. And so this type of study is going to be very limited as far as information that you may need, and in fact, you may not get the information that you need at all because of all this movement artifact. This is a physics issue, and it's called beam hardening. And this happens when the X-ray beam goes from a soft surface to a very hard surface, so a sudden change. Here's an individual with bilateral hip implants, and you can see there's so much beam hardening here that this slice at least is virtually useless. And a similar, a little bit more attenuated version on this side, we've got this central kind of area missing, and then some streaks here going in different directions, and that's due to beam hardening when that beam hits metal. And here's another artifact. Now this is a instrument issue. So this is what's called a ring artifact. Here's one ring, very small. Here's another one. It shows up as a shadow in this head scan. But this is due to the machine itself, a faulty or missing detector in the gantry. All right, so that was the easy one. Let's go to the hard one, MRI. How does this work? I'm not a nuclear physicist, so I'm going to try to be very simple here. Essentially, you get a patient and you place them in a very, very strong static magnetic field. You're going to add different other magnetic fields called gradients. And that magnetic field, what's going to happen is the protons, and we use water or hydrogen protons, when they're subjected to a magnetic field, they all align in one direction, right? And they tend to cancel each other out. However, there are some that maintain their intrinsic spin, which is called, it's not senescence, anyway, I forget. When you apply a radio frequency current, a particular current, it affects them and knocks them out of their equilibrium state, and they start spinning and spinning off their axis. The signal actually comes when you stop this radio frequency current, and they emit energy when they relax back to their state, right? So that's what actually is recorded in the MRI scan, and when you record it, it comes out of this strange kind of sine wavy-ish material, which has to be go through a computer and generate it as a scan that you would read or interpret. So here are the components of a basic MRI. So this outside, the big giant magnet is extremely powerful, in several Teslas in power. And in order to get this is a superconducting magnet. So all the coils involved in this very large magnet are sitting in a housing with liquid helium. And that liquid helium is also subjected to a vacuum, and it's minus 450 degrees Fahrenheit. And that's to try to minimize any resistant and or heat that's going to be generated in this process. So next layer is going to be a gradient coil, and these are gradient magnets, and these are not superconducted, and they do generate heat. And also you need the radio frequency coils, an emitter or transmitter and a recorder. And all this is housed again in a donut and with a bore. This is usually a small bore, maybe 24 inches, when the patient slides through. Let's talk a little bit about the history of MRI. I like history and how these things developed, but this goes way back. And so in 1944, a group of physicists discovered the phenomenon of nuclear magnetic resonance, which is what I described when you apply a magnet field and radiation, and they line up and eventually relax when their field is disturbed, and they relax back to equilibrium state. So that actually won a Pulitzer Prize for this work, and then a lot of time lapsed until the 70s, where the addition of these magnetic field gradients allowed them to record spatially information, so from a different part of the body, and these magnetic field gradients move around, right? And that allowed the images to be recorded in 2 and 3D using gradients. And then in the late 70s, this was performed first time on a human being, and by 1980, it saw clinical use. First patient, they demonstrated metastasis as well as a primary tumor. And from then on, it just caught fire and took off. All right, so a little bit about terminology. When describing an MRI, it's all relative. So we talk about signal. A white signal is a bright signal. I'll be talking about that a little bit later. Intermediate is gray, and a low signal intensity is black. When you describe appearances, you talk about relative intensities. So this white lesion is hyperintense to the brain, gray and white matter here. And then hypointense would be a black lesion to this material. So you hear these hyperintense, isointense, and that's what these terms mean. And when you talk about sequences, so this is where the physics kind of get away from me, spin lattice and spin relaxation. But what the important information is, what's the difference between T1 and T2? And these are the workhorses, essentially, of any series. Almost all of them have T1 and T2. So T1 shows high signal content for fat and a lower signal for tissue that has a higher water content. In T2, that relationship is reversed. So you get a very high or bright signal for anything that has a high water content and a low signal for fat. So this information should be complementary. Here's an example of a brain scan for T1 and T2. And this T1 is thought to be kind of a more anatomical look to the actual tissues, i.e. there's not that much contrast here, and it's supposed to look like more what you would see just on a gross examination, so not artificially contrasted. But you apply T2 sequence, and that changes, so all this CSF material suddenly lights up, and you get more contrast here you can see it in the white matter and the gray matter, as well as anything that's got CSF. So kind of complementary. What are the advantages of MR? So as opposed to CT, it does not use radiation, so you don't have to worry about overdosing your patient on radiation. This modality is superior for soft tissue contrast, so we're going to see a lot of this when we get to the bone and soft tissue world. It's also really good for the nervous system. It's beautiful in the joints where you can't see details on CT. And you can do fancy things with it like, angiographic imaging and functional MRI and all these advanced techniques that allow for more precise tissue characterization. What are the disadvantages? Well, the scans tend to be more expensive. They take significantly longer to acquire than CTs. The patient comfort can be an issue. If you ever had one of these exams, and I've had two, it just is the weirdest sounds, clop, 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 and clang, clang, clang. It's a small bore, so some people have trouble in there with claustrophobia. And the big one is that it is absolutely not safe if you have a metal implant or foreign body. Costs, similar to CT, maybe a little bit higher, and same issues apply. Are you doing just one limb or, the distal extremities versus, an entire sequence, geographic, and then, issues with reimbursement. So they tend to be on the expensive side. All right, and again, I'll finish up this section with a little bit more on artifacts. So this is a patient artifact, again, motion, but this gives you like this ghosting artifact. So here's the main image, and if you look on either side, there's a ghost on either side of this patient's head, and it's actually due to motion. This one, it shows you how sensitive this modality is to motion. So this is just normal peristalsis, which has given you a kind of similar ghosting appearance. Here's an artifact called zipper artifact right over here with these parallel lines. And this is due to background radiation frequency noise. In this instance, it was secondary to a machine required for this patient who's getting anesthesia. And kind of another issue is the herringbone artifact, also known as a spike artifact. Usually this is caused by some kind of spike in the electromagnetic field, either generated by the gradient magnets, some type of electronic equipment within the MR room can cause this, or even a fluctuating current. So let's see, I think I'm turning it over to my buddy Sarah for her part of the talk.
All right, thank you, Leslie. And I realized that at the beginning, we mentioned that we don't have any disclosures, but something I meant to say at the beginning of the talk is, we're not medical physicists, we're not radiologists, and we're not here to try to teach you to be radiologists, right? But just like, the physical exam is something you learn in medical school and you still use these principles, knowing a little bit about radiology, artifacts, and the different imaging characteristics is so important because it's like part of our physical exam. It's part of your gross exam, especially for people who, like the two of us, do cytopathology. Seeing the imaging characteristics is really important. So that's why, we decided the session would be good, just so people can learn a little bit about radiology. But again, disclosure, we are not radiologists. We are not here to teach you to be radiologists. So in thinking about ultrasound, some of the basics of ultrasound is basically, again, I'm not a medical physicist, but I think of it in very simple terms. So the little transducer emits waves from piezoelectric crystals. Don't ask me what that means, but it's very fancy and they're very expensive. And what they do is they basically emit waves, but then the transducer also listens for returning waves, and that's how they create the images that we see on ultrasound. And usually for medical ultrasound, you end up in the frequencies of 2 to 20 megahertz. And the important thing to know about this is that lower frequencies are going to give you greater depth of penetration, but lower resolutions. Whereas for higher frequencies, you're going to get higher resolution, but the waves aren't going to penetrate as much. So depending on what your application is, you might want to use different frequencies. And often your ultrasound machines, if you have them, will come in with presets, and ours does. In terms of, how ultrasound makes its images, it's kind of similar to the way MRI and CT makes images, which is that different tissue types will absorb or reflect ultrasound waves to varying degrees. So for instance, blood, you'll have a lot of, fluids, cis fluid, blood. They're not going to either absorb or reflect very much. Soft tissue is going to have a little bit more. Fibrous tissue is definitely not going to let as much of the wave through. It's going to reflect more of the wave. And solid things such as stones and bones, they're really going to impede that ultrasound wave almost entirely. And so there's a couple ultrasound modes, and the one that we typically think of in pathology, the one that I use in my FNA clinic, is B, or brightness mode, and it's basically your little grayscale 2D image in a 1 millimeter slice through the tissue. So here, and for all my ultrasound images except where otherwise noted, they are images from our own clinic. So here you think of your slice through the level of the thyroid, here's your trachea with some posterior shadowing, here's your right thyroid, and here, which of course comes conveniently labeled, of course, on all our ultrasound machines, and then some cystic changes. There's also M mode, or motion mode, in which the ultrasound is imaging one line over time. This is not something we really use in pathology very much, but in cardiology, this is something you use when you're looking at valves. And so you can see this image. This is an image through a cardiac valve. Here's your line that's being imaged over time, and you can see the valve opening and closing. Again, in pathology, we don't tend to use M mode because it's not as applicable for our lesions. One mode that I do use a lot is Doppler mode, and so Doppler is where the machine measures the direction and speed of tissue and blood, and really when we're thinking about pathology in our samples, we're thinking about blood motion, right? So this is an image from our clinic looking at the right neck with some large vessels in the right neck. So I actually use this quite a lot in our clinic because, if you're scanning, you might not know if something cystic is cyst or a vessel. And obviously, if you're planning to stick a needle into it, it's important to know whether it's cyst or a vessel. Echogenicity terms, much as with our MRI, the echogenicity is basically used relative to your background tissue. So anechoic is going to mean it's basically black, blood, cyst fluid, things like that. Isoechoic would be the same intensity as surrounding tissue. Hyperechoic, brighter than surrounding tissue. Hypoechoic, darker than surrounding tissue. And so let's talk about artifacts. So I think artifacts are really important if you're running an FNA practice because it's an opportunity for you to see lesions that are not there because of artifacts. So a very important one is posterior shadowing, and this is basically anything that is going to impede your ultrasound wave, you're not going to be able to see behind. So for instance, here we have one of your tracheal rings, and everything behind it is going to be black because the ultrasound wave is not penetrating your tracheal ring. Other things that are going to be strong absorbers like bone or stones, you're not going to be able to see it. And actually, if you have air, so for instance, the trachea, hopefully in your patients, is filled with air, and that ultrasound wave is not going to be able to penetrate it. This also means that if you're running an academic practice and your trainee doesn't put any gel between the probe and the probe cover, you're going to have a big air bubble, and you're not going to be able to see anything. So I have run into this many times where my trainee has sworn to me that they put gel on, and they didn't. And they're like, "There's something wrong with the machine, Dr. Jang." And I'm like, let's just take that probe cover off and put some gel on. Easy troubleshooting. I know, if only all our problems were so easily solved, right? Another thing that can happen is actually posterior enhancement. So an area behind an anechoic structure, so for instance, a big cyst in the thyroid, is going to appear brighter than the surrounding tissue. And I think this is a particularly important one to be aware of, because if you don't know that you're going to get posterior enhancement behind this cyst, you might look at this image and say, oh my gosh, there's something really weird and hyperechoic behind the cyst, let's target it. But if you realize that, oh no, it's really just the posterior enhancement you see behind the cyst, then you won't go sticking your needle into a lesion that doesn't exist, or saying the patient has a lesion which doesn't exist. Other artifacts you can see, you can get reverberation artifact. This is not my image of a BB, again, conveniently labeled, in someone's neck, and a very strong reflector, an air bubble, a piece of metal, is going to create this comet tail artifact behind it. You can actually see this in the thyroid. If you have a really coarse calcification in a thyroid nodule, you can get a little bit of comet tail behind that. And I think this one is more obviously an artifact. You're not going to go like, oh, there's some linear thing in the patient's neck, but just good to be aware that that's something that can happen. Some of the artifacts can actually help us. So there is a speed propagation artifact, which is your ultrasound machine basically uses 1.54 millimeters per microsecond as an average speed of sound in soft tissue. So if the sound travels faster in the tissue, so anechoic, hypoechoic structures, a reflector is going to appear closer to the transducer than its actual depth, and vice versa. Why is this helpful for us? It's actually the basis of the bayonet sign. So this is a bayonet, you have a little gun here and this little curvy thing stuck out. And this is the bayonet sign in tissue. I took this from David Liu's very nice paper. But you see how it looks like the needle has actually bent when it went into the lesion? So because this lesion is anechoic, it's cystic, it has a different intensity than the surrounding tissue, the machine, the way it processes things, is going to make that tip of the needle look closer than it actually is. And it's actually a very helpful sign, because if you see this bayonet sign, you know that your needle is in the lesion, right? So it's actually a helpful sign. And it's just, kind of fun to see your needle kind of bend when you put it into a cystic lesion. So some of our artifacts actually can be helpful for those of us who do biopsies. So what are the advantages of ultrasound? I think the first one for those of us who are cytopathologists is you can biopsy non-palpable lesions, right? You don't have to just stick people blindly if you can't feel it. You can directly visualize your needle tip, which is nice, especially if you're in, the head and neck area where there's a lot of valuable real estate. You might want to know where your needle tip is. And you can avoid trauma to important structures, such as these neck vessels that I've shown you here. I have to say, we were at Duke doing ultrasound-guided FNA for over a decade, maybe 15 years or so. And in our practice, we did a lot of palpation-guided biopsies. We'll talk a little bit more about the clinic more. But I have to say, as a cytopathologist about to stick a needle in someone's neck, if it's very close to the carotid and I can kind of feel the needle bouncing up and down with the pulse, man, it makes me feel so much better to throw the ultrasound on and, number one, see that it's not a carotid body tumor, and number two, see my needle and be able to avoid the carotid. So it just, it's helpful to have that extra little look. In terms of ultrasound FNA technique, you can either do in-beam, which is, I think, what most people usually do, where you have the transducer and you align your needle in it so you can see the needle along the whole track. You can also do perpendicular transducer or out of beam, where you just have, the needle go through at one point. There's very few instances where, I would use that technique. And then in terms of your actual FNA technique, don't know why my transducer just duplicated itself there, but it is what it is. You can either use a needle guide, which is illustrated here. You'll see the radiologists tend to like to use these. And the benefit of having the needle guide is if you use it, you're going to see your needle, it's going to be at a specific angle. The downside of using the needle guide, and the reason I think a lot of cytopathologists don't like to use the needle guide, is it really removes your flexibility. So if you stick the needle in, you see, oh, I really want to readjust, it's very difficult to move your needle out and readjust. And so for those of us who are used to doing palpable, kind of more freehand, it makes it just feel a little limiting. And then of course you can use the French technique, you can use a suction technique, you can use tubing, you can use a needle holder. And so just like in palpable FNAs, there's a variety of ways you can do it. And, one of the things that's kind of, happened over the last couple decades is that more and more pathologists are doing ultrasound-guided FNAs. And so looking at the efficiency, right, because anytime there's a turf battle in place, people are going to be like, well, you guys are pathologists, you don't work with real living patients, are you going to be good at it? And fortunately, we've had, some real pioneers in the field. This is David Liu's paper. If you scan the QR code, you can get to it, or it'll be in your handout. He put together a series, basically, of, 500 lesions that he did under ultrasound guidance, basically proving that pathologists can do these procedures with a very, very high rate of adequate samples. So if you look at the locations that he biopsied, we've got thyroid, breast, head, neck, and other sites. And you can see the diagnoses there, but if you look at the satisfactory rates, the overall satisfactory sample rate was like almost 99%, which I think is an incredible performance for really anyone. And so, Dave Liu really was one of the first to kind of publish his experience with this. He still teaches, I think, the CAP ultrasound guided FNA course. So if folks in the audience are interested in more expertise, that's a great resource. Another one of the early pioneers was Mao-Xun Wu up in New York, and what she did was she did a series of 100 palpation-guided FNAs, 100 ultrasound-guided FNAs. It was all her. Again, this is a single operator, someone with a lot of dedication to this technique, and you can see that actually her non-diagnostic rate went down from 7 to 1% using ultrasound guidance, which again I think is really incredible performance. So just to show you a sample workflow from our practice at Duke, basically we had a walk-in FNA clinic, and clinician would page the FNA team. The patient would arrive to our clinic room. This is the waiting area. This is the actual clinic room. This is an older machine. We got a bigger, newer Philips machine. But basically the clinic staff would check the patient in. We would do the biopsy, and then the patient would return to their referring clinician or to home. And we had really great feedback, both from our clinical colleagues and patients, because if you're at a tertiary referral center, you've got people sitting through 6 hours, 4 hours of traffic to come, get their appointment. And if they can come that same day, get their biopsy, get it done, and not have to come back for another appointment, not have to miss another day of work, not have to have their spouse drive them, it's a really great tool. And then I think on the patient side, because we were able to, often have immediate results, they could go back to their treating oncologist and start setting up the next steps for, okay, well, you've got residual melanoma, you've got recurrent disease, let's talk about the next steps. So from that patient perspective, it really helps with patient care because, they're able to kind of start that process and they don't have to wait as long. And so we, of course, also academic, wanted to see, so sure, we have these single operator series where very dedicated attending pathologists who've really gone the extra mile to hone their ultrasound-guided FNA skills, they can do great. But what about in an academic institution where you've got 8 cytopathologists and a rotating cohort of residents, fellows, trainees coming through the clinic? What is that performance like? And so in typical academic fashion, I offered an opportunity to my one of my wonderful residents, Dave McKenzie, to look at our series. And what we can see here in the next slide is we looked at first just the thyroid biopsies, because that's really the vast majority of where our ultrasounds were. And you can see that over the time, we had about a 7% non-diagnostic rate, which I will confess is higher than those in Dr. Liu and Dr. Wu's series. But again, we're running a clinic where we have a whole bunch of different trainees, we have a whole bunch of different physicians, and then also these ultrasound-guided nodules are obviously going to be the more potentially challenging ones, because we'll still do a big old palpable thyroid nodule under palpation. So, it is kind of a little bit of a selected population of more difficult nodules. But I think, you see that the 7% non-diagnostic rate, it's not too bad for a place where you've got a whole bunch of learners. And so the next step was, of course, to look at the non-thyroid sites. So I volunteered. I gave another opportunity to one of our other residents, Dr. Kleosoff, to look at our extrathyroidal sites and look at what our performance was. And here you can see a lot of what we ended up biopsying was called neck, and usually this is going to be your head and neck lymph nodes, some salivary glands, some soft tissue, some abdomen. And again, these were kind of retrospective studies. So all of these nodules that were done outside the thyroid with ultrasound guidance would have been cases where we felt like the lesion wasn't palpable, it was small, it was close to adjacent structures. So again, a population where we are already selecting for more challenging lesions, right? Because if it's, a very palpable large lesion, we're just going to do it under palpation and, we'll save some time, right? And what you can see here is we had about a 7% non-diagnostic rate, but otherwise we had pretty good performance, even again in a large academic center, lots of trainees, lots of fellows, and looking at a selected population of pretty difficult sites. So I think, the literature supports that pathologists can do ultrasound-guided FNAs and that, we have pretty decent performance, and I think it just makes sense, right? So we are the people who are the specialists in diagnostics. We, in cytopathology, have a long history of doing palpation-guided FNAs, and so having that ultrasound has really been a tool for us to be able to expand our reach. And again, in our practice, I wouldn't always do the biopsy under ultrasound guidance because, you got to get the machine and do the thing, and then, it's more. If it's an easy palpable lesion, I won't always use it, but having the ultrasound is just so nice for those lesions. Again, if they're sitting next to the carotid, sometimes, you have a big old mass in the neck and you do the first biopsy, you get nothing. You put the ultrasound on, you say, oh, it's actually much deeper. There's just a bunch of fibrosis or muscle around it, and you can, get your bigger needle and go further. But it's really been a great asset to have. And I think that with technology, they have now, these ultrasound machines that are basically iPads connected to a transducer. So the barrier of entry for getting access to ultrasound technology has really become a lot lower. And so I'm a big proponent of, adding ultrasound guidance to your practice if you haven't already. I know there can be definitely some turf-related issues in terms of, working with endocrinology or surgery or radiology in terms of the patient mix, but at least at Duke, gosh, we had so many thyroid nodules. I think everybody was super happy just to have someone else to, help biopsy them. So we're going to shift gears a little bit and show some pictures. So it's now picture time. In the second half of the talk, we're going to talk about radiology pathology correlations in kind of some different sites. And I'll start us off with first talking about head, neck, and lymph nodes. And again, with the caveat, again, not a radiologist, but if you probably read radiology reports, you probably look at them, and if you're doing ultrasound, it's really important to kind of understand some of the buzzwords that we use. And so very common site that we see in the head and neck would be lymph nodes. A lot of times we'll just get suspicious lymph nodes, and some of the normal ultrasound characteristics of a lymph node are that there is a short axis to long axis ratio of less than 0.5. And what does this mean in layman's terms? Normal lymph nodes are pretty much oval. So here you have a little lymph node, again, pre-measured by my resident. And you can see that the short axis to long axis ratio is right about 0.33. And you can see it's kind of a nice oval shape. You can see that's a little bit hypoechoic, maybe some posterior shadowing. This would be a normal kind of morphology for a lymph node. Another normal ultrasound characteristic for a lymph node is an echoic fatty hilum. So if you think about looking at lymph nodes on SearchPath, right, you got your little hilum, your vessels and fat are in there, and I will say, I think this is a little bit more difficult to appreciate on ultrasound, which is why I pulled an image from the website, but you get this kind of hyperechoic fatty hilum normally, and normally the vessels in the lymph node should be in this central area. So if you put a Doppler on, that's where the vessel should be. You shouldn't have a whole bunch of lymph vessels out in the periphery. So what are some concerning findings for lymph nodes? If you start getting a high short axis to long axis ratio, and that basically means if your lymph node moves from oval to being more round, that's worrisome. Things like taller than wide may be concerning because that's going to be not your normal configuration for a lymph node. So this one, for instance, it's much more round, right? I mean, and in real practice, do I go, oh, let's measure it and calculate the short to long ratio? No, I just look at it and I go, that's a weird shape. It's not oval, it's more round, it's taller than wide, right? So that's what an abnormal lymph node would look like. And then another finding that would be concerning would be internal heterogeneity, right? If you look at this lymph node, there's stuff in there. That's not good. And this is something that I think is really fun and satisfying about using ultrasound is you really can, look at the ultrasound and just picture in your head what that's going to look like on histology, right? You're going to see something that isn't supposed to be there. Like in this case, an example of a metastatic adenocarcinoma from the lung, right? And so I think really it's almost like if you're used to looking at a gross exam, the ultrasound is like a little black and white, thin slice gross exam. So, it's really not that complicated, right? What are some other concerning findings? If you have an irregular margin with the surrounding tissue, obviously that's worrisome for extranodal extension. If your fatty hilum is absent, though I will say, like I said, I think this one is a little harder to find. And then if you've got a whole bunch of internal vessels, right, that's going to be abnormal because normally in the lymph node, you should not have a whole bunch of vascularity outside the hilum. You can get cystic mets as well. So this is very, very commonly seen in the head and neck. So you'll get cystic metastases from either a thyroid cancer or a head and neck squamous cell carcinoma. So this is an example of a lymph node that is, while it is hypoechoic, which is normal, it's a little bit like too anechoic, and it's kind of a weird shape. So this is a big cystic metastasis from a papillary thyroid carcinoma. So just some examples of benign and concerning features in lymph nodes. We'll talk a little bit about salivary gland. So the most common lesions that are benign that we'll see would be things like PA and Warthin tumor, and both of these types of tumors tend to be hypoechoic and well circumscribed. So this is an example of a Warthin tumor. You can see the background salivary tissue here, and this lesion very well circumscribed, relatively hypoechoic, and then you can actually see some little cystic areas in here as well with these anechoic areas. The caveat with this is, PAs can have a lobulated border, so just because it has a lobulated border, still could be PA. So again, just a nice example of a radiology cytology correlation on a Warthin tumor. And again, these are very, very common. If you are doing them under ultrasound guidance, it can be nice to kind of maybe like target the not cystic areas. This is something that's really great. So even for palpable lesions, if I throw the ultrasound on, I see there's a cystic area. It's so nice and satisfying just to be able to stick your needle in the cystic area and drain it, and then you can target the remaining components, right? Because otherwise you get cystic stuff and you're like, cyst contents only. But with ultrasound, you can really target that solid component, which is going to give you the cellular material you need to make a definitive diagnosis, at least sometimes in salivary gland. So malignant neoplasms tend to be irregular in the salivary gland. They can have spiculated or indistinct margins. They can be heterogeneous. So you can see here, this is a more irregular lesion here. And then this one has almost, it looks like a second, more heterogeneous component that's protruding out here. And you can get some internal calcifications as well. So this was an example of a salivary duct carcinoma with very irregular borders and a little bit of calcifications or necrosis within. So moving on to thyroid. Thyroid, I think, is definitely the area that I have spent the most time on looking at ultrasounds, and I think probably in most of our practices, we see so much thyroid, right? And so with thyroid radiology, you really have to think about two main risk stratification systems. Sometimes it feels like literally everybody in the world has a thyroid nodule, and literally every single one of those thyroid nodules has come to my office in a flat of a whole bunch of bloody slides. But there's actually two different clinical risk stratification systems to try to select for, when do you need to biopsy these thyroid nodules. So first I'll talk about the American Thyroid Association, or ATA, risk stratification system. And this is probably projecting a little bit small, but this is from the most recent guidelines. The ATA is coming out with a new set of guidelines to look out for that. But basically these guidelines will take a look at the ultrasound features of a nodule and stratify into benign, so this almost totally cystic nodule on the bottom, almost totally benign, less than 1% risk of malignancy, very low suspicion, which are these spongiform nodules, partially cystic, low suspicion, which are these kind of hyperechoic with regular margins, isoechoic with regular margins, partially cystic with some mural nodules. Intermediate suspicion would be some of these hypoechoic nodules, and then high suspicion would be nodules that have some microcalcifications. They've got irregular margins, they've got some areas of capsular penetration. So what the ATA risk stratification system does is they look at the ultrasound features of a nodule, and they give it a size cutoff. So depending on what your ultrasound pattern is, they will give you a size cutoff for when to do the biopsy. So for instance, for these benign anechoic cystic nodules, basically no matter how big it is, you don't need to biopsy it. Versus if you have a high suspicion, if it's over a centimeter, you should be biopsying it. So this way they can take into account kind of, both the ultrasound findings and the size and give a recommendation for when to biopsy. Because again, these thyroid nodules are so common. If you biopsied every single one, it would just drown us in thyroid cytology, which even, I who love thyroid cytology don't want. I will say for the cystic nodules, if they're completely cystic, they would sometimes send these patients to my clinic just because you can kind of drain these cystic nodules. And if the patients are having symptoms like, compressive symptoms from this 4-centimeter cystic nodule, if you drain it, they do feel better. I will say usually the fluid reaccumulates, but at least you can feel like, you did something for them in that moment. So that would be the only reason to biopsy these like totally cystic nodules. So we'll shift gears to ACR TIRADS. My apologies, I know this is a very busy table, but essentially the ACR TIRADS, the ACR is American College of Radiology, it does something very similar to ATA, which is it takes different elements of ultrasound, so composition, echogenicity, shape, margin, echogenic foci, it assigns them a point value, and then depending on what the point value is, you'll once again have kind of different cutoffs for FNA. So if it's 0 points, totally benign nodule, no FNA, no matter what size. If it's highly suspicious, high point value, you're going to do an FNA, if it's greater than a centimeter. And for the most part, these two systems have very good agreement. I did some work at Duke with my colleagues in surgery and endocrinology, showing that basically if you score the same nodules with ACR TIRADS versus ATA, for the most part, the recommendations are the same. However, the TIRADS 3-4 group, these mildly and moderately suspicious, if you score them with TIRADS versus ATA, you could miss some carcinomas. So these are the two systems that are very commonly used. And if you look at your radiology reports, they'll usually have either an ATA or a TIRADS risk stratification system. So let's look a little bit more at what are some likely benign patterns. So like I said, if you have a large, predominantly cystic nodule, these are usually going to be benign. Cystic thyroid carcinomas usually don't have cystic change occupying more than 50% of the nodule. And if it does have a mostly cystic appearance, it may have some worrisome features like calcification or abnormal vessels as well. If you have these kind of honeycomb nodules, these spongiform nodules, these tend to kind of correlate with, your nodular follicular disease or colloid nodules, so a little radiology, pathology correlation, right? You're seeing cystic areas in a benign nodule. Other low suspicion nodules would be markedly hyperechoic solid nodules with a regular border. These tend to be colloid nodules, or you can have focal nodular Hosh. This one is a little bit, if you look really closely, it looks a little bit moth-eaten, that there are little like black spaces in there. And if you hear the word moth-eaten on ultrasound of thyroids, it is basically a buzzword for thyroiditis, and specifically chronic lymphocytic thyroiditis or Hashi. And again, I think it's really nice because you can get this kind of like gross image, right? So you've got your little hypoechoic areas, which correlate with your lymphoid follicles in really florid Hashi. And then here's your, very nice, beautiful FNA from a case of chronic lymphocytic thyroiditis. What are some concerning patterns? So if you start seeing nodules that are hypoechoic, so this one is a little bit irregular, it's a little bit hypoechoic, and then this would be the appearance of something like a papillary thyroid carcinoma where you've got an irregular hypoechoic lesion and they're a nice cytology. Other concerning findings would be solid oval nodules with a thin capsule, which are everyone's favorite. Follicular pattern lesions, and both benign and malignant follicular lesions are going to look like this. If you're very fortunate, you might see some evidence of capsular penetration on the ultrasound, but let's face it, even on SearchPath, it can be hard to find those areas of capsular invasion. So usually you're going to see a pretty well circumscribed lesion. And again, this is what both benign and malignant follicular lesions look like. And here's a nice little follicular adenoma on cytology as well. What are some super concerning findings? Irregular borders or calcifications and taller than wide. So just like in lymph nodes, if you get taller than wide, it's concerning. And the thyroid nodules that are taller than wide are concerning as well. And these would be the appearance of papillary thyroid carcinomas. All right, so that takes us to the end of the thyroid, and I'm going to turn it back over to Dr. Dodd for some GI and BST imaging.
Wow. Okay, I'm going to try to keep up with you, Sarah. Okay, let's see. Let me, oh, I forgot my glasses. All right, we're going to start out the GI block here with some luminal pathology. I'm going to start with the esophagus, and I have some landmarks here, and this is black. It's an air-filled tube that sits behind this other black trachea air-filled tube, right? So it can be a little, and then the air-filled lungs, of course. So it can be a little bit difficult to visualize. We just got to know which one we're looking at. Heterogeneity is a word I'm going to use a lot too, in addition to moth-eaten in a different setting. So let's look at some things of the esophagus. So benign tumors, after all, I talked about CT and MRI. I'm going to show you barium swallow, but it helps us kind of get our bearings here. So benign tumors, there are many in the esophagus. You can get leiomyomas, are very common, lipomas, granular cell tumors. They have I didn't illustrate one, they have a slightly different appearance. But they have a very nice, smooth contour. They protrude into the lumen, usually giving you some kind of obstruction or dysphagia or something like that. Okay. Here's an example of a leiomyoma in the wall of the esophagus. Normally, you wouldn't remove an esophagus for a leiomyoma, but for some reason it happened in this case. And our gross and histopathology correlation. Interestingly enough, like the leiomyomas you get in the GYN tract, occasionally you'll have a little bit of calcification within this leiomyoma in this area. So here's another one. This one's a little bit harder to see. Here's our dark esophageal lumen. Here's a lesion, again, protruding into the lumen. It's kind of like a dark lesion. Here it is again. But this one is a lipoma, so same principle. It's going to protrude into, instead of invading the lumen of the esophagus. And let's contrast that picture to this. So, same buzzwords I'm going to use. So this is heterogeneous. It is poorly defined, and this is a carcinoma, kind of the lower esophagus, almost to the GE junction. Best illustrated here on this coronal picture instead of here on this axial. I think it doesn't do it as much justice. Next entity, gist. So these are common, and more common in the stomach than this example that I'm showing you, which is from the duodenum. They're typically lobulated like this, right? They can be heterogeneous, they're lobulated. And this one has a special feature. So in the middle of this thing, this is an area of air or maybe gas, probably air. And this means that this lesion has a central cavity of necrosis, all right? So this is most likely to be on, because of size, and this feature going to be on our more aggressive spectrum for gist. Gastric adenocarcinoma. Normally you don't use cross-sectional imaging to diagnose a gastric carcinoma. That's going to be, EUS typically. However, you do use it for staging purposes. So here's our opportunity to take a look at a gastric adenocarcinoma. It's a mass that protrudes into the lumen, this time heterogeneous. It can ulcerate. It can penetrate the gastric wall here, but clearly a malignancy in this setting. And here's a real fun one. This is a kind of a special type of gastric adenocarcinoma where you have diffuse infiltration of this wall with narrowing of the space here and here. And this one's pretty diagnostic, and you just need to support your diagnosis with a gross and microscopic. So this is a linitis plastica. This particular example is not all the way around, so we still have folds here, but here it is infiltrating the wall. And you have this nice signet ring type of adenocarcinoma morphology. All right, well, that was brief. I'm going to move into the pancreas for the rest of a GI section here. There we go. So I put this together, and I wanted to kind of divide it into solid lesions and cystic lesions, focusing on pancreatitis versus adenocarcinoma. And it kind of sort of worked out that way, but it kind of sort of didn't. And I just decided to keep this formatting. But we're going to talk about the differences between pancreatitis versus pancreatic ductal adenocarcinoma. And when I'm talking about, pancreatitis, there are different types. So there's an acute type of pancreatitis, gallstones, impacted gallstones typically. And usually you get edema and inflammation in the organ, and usually you get an enlargement of the organ. And that's not a diagnostic dilemma so much. In the pancreatitis that I'm going to talk about, which is chronic, usually in the later phases or more severe cases, you get atrophy of the organ. So those two entities are they're very easy to distinguish from each other. And then there's this autoimmune pancreatitis as well. But I'm going to illustrate here chronic pancreatitis for our purposes. What happens in chronic pancreatitis, as I mentioned, late stages, you're going to have atrophy. One of the most reliable signs of chronic pancreatitis are these little calcifications all throughout the gland here. Okay, that's pretty diagnostic for pancreatitis. Another thing that can happen is dilation of this duct, this main pancreatic duct, very dramatic on this picture, this coronal picture here, a large dilation. Now, chronic pancreatitis is, I don't know, but I don't know that it's sampled all that much, except for one issue, and that's this autoimmune pancreatitis, so we still get some sampling for that. And autoimmune pancreatitis actually doesn't look like this other chronic pancreatitis. It usually is a diffuse enlargement, infiltration of the pancreas with a halo around it. However, it can also form a mass-forming lesion, so it is going to be in the differential for ductal adenocarcinoma. I actually had to one time refuse samples, FNA samples, to rule out immune-associated pancreatitis because I said I couldn't really tell you on cytology, so they went to core biopsies. All right. So let's look at ductal adenocarcinoma for contrast. And all these images that I'm showing you are extreme images, of course. And I wanted to do that because, it's easier to see the features. Real images probably aren't going to be this obvious, but, and that's why we're not radiologists, we're pathologists. But I think hopefully you can find these principles helpful. So here's an example of a ductal adenocarcinoma, very diffuse, heterogeneous, and maybe some fat stranding here. This is involved the head of the pancreas. This is a different level here. A lot of things happen in adenocarcinoma. Often you're going to have dilation of the gallbladder because of obstruction of this duct here. And you're also going to have dilation of the distal ducts. Now, if you got a sample from a pancreas, which is rule in, rule out, adenocarcinoma, you got something like this, you're set, right? Not a problem, but that's not what you get. You're, of course, going to get a small biopsy or a cytology biopsy, and these are much more difficult to interpret. I always get a little, I always hyperventilate a little bit when I have to make this diagnosis because the stakes are really just so high for this patient. So what can help you? Well, there's one thing that really is helpful, and that's this double duct sign. And it's not 100% specific. However, it is really, really a good indicator of malignancy or a ductal adenocarcinoma. So, and it refers to simultaneous dilation of the common bile ducts, hepatic ducts, as well as the main pancreatic ducts. And this dilation, actually, for this hepatic duct can extend all the way into the intrahepatic ducts as well. And this occurs in the head of the pancreas, and also ampullary tumors can cause this double duct sign as well. And so I had to really get some really good images. And by the way, These are not my images I got for this GI section. I refer to a great resource for you, learning resource, and that's this Radiopedia. It's essentially, a lot of these images are free, and it's a great study source, so I used for this section. Well, anyway, here's double duct sign on the axial, a really good view of it right here. A hepatic duct and a pancreatic duct side by side, so that's a double duct and one more view. I think of that. Here are the ducts side by side. Here's our enlarged gallbladder. That's often called a Cavassier gallbladder. All right, cystic lesions of the pancreas. I started going through this and I said, this is a big, big category. So I decided to narrow it down a little bit, and I'm not going to really go over these mucinous cystic lesions because it's quite complicated. And I think, as you know, when you're evaluating these, we're going to depend a lot on the serology of the cyst fluid, as well as, even now, moving into molecular diagnostics applied to these neoplasms. So I'm going to focus on just a few neoplasms, including this one, which is sometimes cystic, not always, but sometimes cystic. So the most common cyst is, of course, going to be this pancreatic pseudocyst, which is a sequela of a chronic pancreatitis. And they're pretty easy to diagnose. So you have this really, really thick wall here, and well-defined cyst, and you have kind of this speckly material inside the wall that corresponds to the junk and debris that's going to be present in a pseudocyst. So here's another lesion that this has IV contrast applied to it, so we can see really nicely that this is multiple little cysts divided by thin septae in the head of the pancreas here. So this is a serous cystadenoma, and the histology correlate for this is these fibrous septae lined by a simple kind of low cuboidal layer of epithelium. And the pattern on these, the majority of these are going to be like multiloculated cysts, but about 20% of them kind of have a really pretty honeycomb pattern to them, but that's not the majority. Here's another one. This is a solid pseudopapillary tumor of the pancreas, most likely to occur more in a distal site here, different phases here with contrast showing you, yes, it's solid, it's very, very well demarcated, but it can occasionally have some centrally kind of cystic degeneration. And as the name implies, solid with pseudopapillary areas of a fibrovascular core with a kind of a clinging residual epithelial layer. Okay, let's move on into my favorite categories, and this is where I think the imaging really becomes critical to evaluation, and that's soft tissue and bone tumors. Of course, bone tumors, but I've learned over the years that you can really tell a lot about a tumor with imaging of soft tissue. So again, what are we looking for? Features that are very helpful. Is it circumscribed? Is it infiltrative? Is it superficial or deep? Heterogeneous again, that's a bad sign universally. Is it bright on T1 or T2? I love this one. Is it connected to another structure? And I'll show you examples of that. And of course, is there necrosis or internal calcification? So here's an example of circumscribed versus infiltrative. And interestingly enough, this is the malignant lesion, right? And so I actually show you a kind of a curveball here for the first slide. This is low-grade fibromyxoid sarcoma, but it's a low-grade lesion, small, nicely circumscribed. This is an infiltrating fibromatosis, so technically a benign lesion, although locally aggressive. So, you have to, I guess, use multiple factors in evaluating these. Heterogeneity. So this one, which is a myxoid liposarcoma, has kind of this diffuse heterogeneity pattern here in multiple lobules. And this one has a different pattern. So we've got a lesion that's isointense to fat, subcutaneous fat that's very, very bright and circumscribed. And then you've got this hypointense or dark lesion here. And what this is a low-grade lipomatous tumor or lipomatous lesion with an area of dedifferentiation. And if you see this kind of change in a lipomatous lesion, you can pretty much guarantee that you're going to have a dedifferentiated component associated with it. Necrosis, not a good thing to see on your scans, and usually even a non-radiologist can pick this up and see, what's happening in the internal aspect of this mass. This is a high-grade undifferentiated pleomorphic sarcoma. Same thing, necrosis here in a head and neck lesion. This actually turned out to be a rhabdomyosarcoma. So again, a really good indication you're dealing with something that's going to be pretty bad. And here are a couple of examples of lesions that appear to be connected to something. So in this example, you have this nodular proliferation attached to the fascia. So this is a nodular fasciitis, and you see that, and that's a really good indicator. So this lesion, very bright, is attached at either end to a tail, and that tail is a nerve. So this is a schwannoma, a benign peripheral nerve sheath tumor. Internal calcification can be telling as well. So here's a large heterogeneous lesion with some punctate-type calcifications, and this is actually synovial sarcoma. So a small fraction of synovial sarcomas, they reported it 40% or so, but I don't believe that. But a lower fraction will have some internal calcifications irregular versus this lesion. So if you see this lesion, this is well organized, and it has kind of a mature type of shell around a central core, and this is a myositis ossificans. So a benign lesion, one of the pseudosarcomas. And of course, does patient age, their sex, and lesion site make a difference? And the answer is yes, it does, of course. So here is a bright on T2 infiltrating lesion in the lower pelvis of a, let's say, younger woman. And this is an aggressive angiomyxoma. You can tell a lot just by, the site and patient characteristics. Here is a lesion kind of on the upper back in, we'll say it's a middle-aged male, and it's got the same signal as fat here. And this is a spindle cell lipoma, which loves this location. All right, so let's look at some correlations in some real cases. All right, first one, this is a 40-year-old female. She has what she describes as a soft lesion near her hip in the upper thigh here. Here it is, it's very bright, it's very nicely circumscribed, and it is embedded in this muscle of the upper extremity. And we actually stuck a needle in this, and this is what came out, this very, very thick gelatinous or myxoid-y type stuff. This is an intramuscular myxoma. It's almost entirely myxoid, hence this bright T2 signal. That's going to be a theme throughout this presentation. And it actually cracked a little bit because it's so thick, and embedded in it are these little small bipolar looking spindly cells. Here's another example. I loved this one. This one was pretty rare, and we managed to figure this out pretty much on clinical features and this imaging. So this is an elderly gentleman. He has limited mobility, spends a lot of time in bed. This is his hip. Right here, this is the femur. And there you have this lesion right here. So it is, again, attached to something. This case is a fascia. This is a fascial plane, and you have this thing right adjacent to this hip. It's bright. So what is it? It's not well circumscribed. This is another one of the pseudosarcomas. This turned out to be an ischemic fasciitis, which is classic for this location. And again, a pseudosarcoma, so you get these strange reactive-looking cells here, but this is a benign lesion due to injury. Here's another case. Here's a 51-year-old female who noticed a right neck swelling, initially painless, but gradually became painful. So if we look, she's got this lesion here. Here it looks to be kind of iso intense to the muscle in there in that lower neck region. So let's apply some different imaging. And we see something here. It stands out a little bit, a knot here, not here. Maybe circumscribed, maybe has like a tail or an irregular edge here. And this turned out, we took this out, this turned out to be a fibromatosis. So fibromatosis, the first example I showed you was infiltrating, and they commonly do that. But this one was a knot, a nodule, and if you looked at the edges of it, you do see this classic infiltrating pattern into the adjacent soft tissue. Here's one of my favorite ones. So a nice circumscribed lesion, and if you look in the middle of it, you have this target sign, sometimes called a bullseye, sometimes called a target sign. This is really, really, in this setting, at least very, almost diagnostic for this. It turned out to be a schwannoma. Schwannomas often have a target sign because in the middle you get this kind of degenerative phenomenon that it will make cysts and things like that. So a very nice correlative, if you can remember that. And you don't always see the tails, because of the plane, but you can see this bullseye often. I think this is the last of my soft tissue cases. So here's an example of a kind of irregular but circumscribed lesion adjacent to the joint. We don't know if it's coming from the joint or if it's attached to a tendon maybe, but it's very close to the bone. On it's my babysitter. T1 and T2, it doesn't really change a lot in its characteristic, maybe a little dark, maybe iso-intense with muscle. And this one came out. And this turned out to be a tenosynovial giant cell tumor, actually probably very common adjacent to joints. These usually have a lot of hemosiderin associated with them, and I'm not sure that that was the correlate with this not really changing its appearance on T1 or T2, but blood and giant cell. All right, we're going to finish up with lesions of the bone, and this is a situation, I do bone tumor pathology, this is a situation when it's actually imperative to understand a little bit about imaging. If you don't, then you got to get a really good radiologist to help you. I've been doing this a long time, so I've been going to a lot of radiology conferences and looking at these for a very long time. And when I get bone tumor biopsies, and I don't even look at the slide, the first thing I do is go to imaging. And I'll be honest with you, over 50% of the information that I need is from the imaging, and I can really either pinpoint the diagnosis or at least, the very minimum, whittle down the diagnosis to just a few things. So what are we looking for? Same stuff, except for is this central, is it eccentric, is it medullary based versus the cortex, deformity, expansile, et cetera. I'm going to add in here a couple of other things, a cortical reaction, so this will tell you a lot, and then texture. So here, ground glass, of course we know what that means, but moth-eaten is associated with lymphoma. And then one aside for those of you who don't routinely look at these, so when you have a bone problem or suspected tumor, you usually begin with just a plain film. So, one of the simplest imaging modalities and least expensive that there are. That will give you a lot of information. See here, probably all the information that you need. But if there's concern or additional worry or you need more information, then they go to MRI. And remember, MRI is superior for bones, joints, and soft tissues because it provides much more contrast than a CT would. And before we get to features, just a little aside, things to consider for all of your patients are age. So, for example, here we have an epiphyseal lesion in a 15-year-old. This individual is not skeletally mature. There's an open physis here versus a 22-year-old where you have a scar, physis scar left, so this person stopped growing. And again, you have a very similar epiphyseal lesion. These are two different things, usually going to be two different things based on just the patient's age, and that age is relative to attainment of skeletal maturity. And the other thing, very important in interpreting these, is the actual anatomic location. So we begin with this area, the epiphysis, which again is below this epiphyseal line or scar, okay? Then you have this long area, and we're usually dealing with long bones, okay? I'll assume that we're dealing with long bones. Long shaft, which is the diaphysis, and then the kind of transitional triangle area in between, which is the metaphyseal region. And I show that because different tumors like to hang out in different places, and usually 90% of the time they're going to stay in their favored sites. Okay, the metaphysis being a very, very busy region, not so much going on in the epiphysis, and then also a handful of lesions that are going to be in the diaphyseal region. So let's look at some imaging. What about this one? So is this destructive? And by destructive, I mean, does it disrupt the cortex? It sure looks like it probably does here on this plain film. Here it is. And then on the MRI, you can be really sure. So you can see, that it's clearly, in this instance, we got a cortex here, and it's destroyed the cortex. So that's your first indication you're dealing with something aggressive. Versus this. So here you have a sclerotic rim. And what does this imply? Well, it implies that you're dealing with a very slow growing or benign or indolent type of lesion. So what's happening here is this host bone is actually pushing back, and it's forming a reaction to like you would in osteomyelitis, right? To encase whatever process is going on here. This happened to be a non-ossifying fibroma, which is actually pretty common in children, and sometimes you never know, you never see it asymptomatic. Sometimes they present with a pathologic fracture through one of these things, but fairly common. And they're usually indolent, and they will eventually go away if you leave them alone. All right, bad things are starting to happen here. So this is a sunburst or hair on end pattern. So here we have a lesion of the distal femur, and look at this kind of hazy area. If you look at it more closely, it's these boom, boom, kind of hair-looking things coming out of the cortex. And this is a bad sign. What this means is you've got a malignant lesion that's growing so fast, it's just like, boom, blasting through this cortex and out into the soft tissue. And based on this, the clinical people and myself, they will say this is either an osteosarcoma or sometimes a Ewing's tumor, right? A Ewing's tumor can do this well, fast-growing, aggressive bone tumors. Here's another thing that happens. So I think this one was a Ewing sarcoma, but again, you've got this up here, you've got this kind of sunbursty pattern, you've got this haziness, destruction of the bone, and then you've got these kind of like stutter lines right here, stutters, where this tumor is, as it moves down and expands, it's actually lifting this periosteum up off the bone. And this is a Codman's triangle. This is another feature of fast-growing aggressive tumors. And you can also get something called onion skinning associated with eventually a Codman's triangle. Again, a very bad sign. What about texture? So ground glass. Of course, associated with fibrous dysplasia. And I don't know what ground glass is supposed to look like, but to me, when I hear this, I think of a kind of a hazy looking appearance, kind of maybe or even fuzzy looking appearance to the bone. Here's another giveaway, and that's fluid levels. And this is the contrast between some cyst fluid, blood, and maybe an partially air-filled cavity. This occurs in a couple of settings. Telangiectatic osteosarcoma and aneurysmal bone cysts usually have fluid levels. This one is obviously on the malignant side, so look at this is the bone, the host bone. This is this hideous giant tumor that's extending out very large into the soft tissue. So this is a telangiectatic osteosarcoma. Is a lesion cortical-based? And if it is, then, and it may or may not involve a little bit of the medullary cavity, but if it is largely cortical-based, you can whittle your differential diagnosis down to a handful of lesions. So there are 2 low-grade types of osteosarcoma that occur in this pattern, a parosteal or a periosteal osteosarcoma. And you can have things like cortical-based enchondromas, even very rarely a cortical-based chondrosarcoma that are, largely cortical in their origin. This lesion, destructive, it occurs at 45% at the sacrum, 45% in the base of the skull, and a handful of cases up and down the slide, and this is a chordoma. And just based on, again, on where this is, gives you a really good idea, but beware. I've seen many of these types of lesions that turn out to be giant cell tumors or regular chondrosarcoma. So just because it's there doesn't mean, also here, chondrosarcoma, doesn't mean it's a chordoma, but it's very helpful sometimes. And then there are these lesions which are so obvious on imaging that they don't biopsy it. So here's an example of one. This is an osteoid osteoma, this little cavity right here in the bone, kind of usually centered on the cortex, but this one's a little off center. And inside you get a nidus of looser bone. It's seldom to see an intact nidus these days because they go in and radio frequency these out, or maybe they'll dig them out, but an intact nidus is rare. And then here, this massive lesion in the soft tissue with this kind of popcorn configuration, or some people call it a cloudy configuration. And this is virtually diagnostic of a chondrosarcoma. Here's a picture of chondrosarcoma with its permeation pattern that you would get up in here. But once it reaches out into the soft tissue like this, then it gets a little peripheral calcification, which gives it that popcorn appearance. Here's another one. It's pretty obvious. So you have an exostosis off the back of the proximal tibia here, and you take this off. It's usually just lopped off all in one, and it's an osteochondroma. You have a little bit of a cartilaginous cap here, which maybe gives you some brightness or irregularity to this surface. All right, so time for a correlation. Here's our imaging, and this is obviously not good. So you have destruction of the central part of the bone. You have this huge hair on the end sign. Maybe somewhere in here you have a onion skinning, or probably out of the picture, out of the view, is a Codman's triangle. So really only 2 things this can be, and here it is. This is a high-grade osteosarcoma. To make a diagnosis of osteosarcoma, you need 2 things. That's sarcoma, so the actual cells in the background, as well as tumor matrix. So this is matrix that it doesn't make any sense. So it's not functional, not trabecular or cortical, irregular matrix. Here's another one. So in this x-ray, we see in the diaphysis of this long bone here, kind of this hazy lesion and some fuzzy things happening to the cortex. Maybe some onion skinning here, fuzzy cortex here, probably hair on in, extension out. And this turned out to be a Ewing sarcoma. Ewing sarcoma, again, a very aggressive tumor, grows rapidly and just shoots through that cortex, just eats it up like it isn't there. Normally, a dense cortex is a nice barrier to tumor. Here's an example. So for this lesion, it looks like this cortex is intact, but there is some scalloping or thinning of this cortex, and there may be even some internal type of matrix or something going on in there, and this was scooped out, and this turned out to be a chondroblastoma. Doesn't really take a genius to make this diagnosis. If you know that a epiphyseal lesion in a skeletally immature person is going to be a chondroblastoma first and foremost, then, honestly, look at the slides to confirm your diagnosis. Here's another easy one, same issue. After I interpret the imaging, which shows this lesion, which is thin the cortex, but it's still intact, and it's got internal fluid layers. I know what this is. And I just get the sides to confirm my diagnosis, and this is an aneurysmal bone cyst these cyst wall fragments are kind of bunched up here, so you don't get the true, cavitary lesion or the cavities with the blood in them. Here's a cortical-based tumor. Not sure if it's going into the medullary cavity, but that's okay. It's a big, giant, dense bone-forming thing off the back of the knee here, or the distal femur. It's maybe even wrapping around. So my differential diagnosis is very, very limited. I'm going to say this is one of the cortical-based low-grade osteosarcomas, and indeed that is what it is. And it's causing this, really, the appearance is caused by this very, very dense trabecular-like bone. It looks similar to normal, how are we doing? Okay, good, I'm on track. Normal trabeculi that you would see in regular bone. In some areas, though, these trabeculi, when they line up in between, you get this very, very subtle fibrous tissue with subtle nuclear atypia. Coming down to the end here, so here's this lesion on the chest wall emanating from the rib, which is unusual for tumors other than this. It has that popcorn configuration. And this is a chondrosarcoma. So chondrosarcoma normally blasts through and encases the native bone, and when it gets out into the periphery, there is some resistance with this peripheral calcification. Coming down to my last case. Here's a kiddo with multiple foci of ground glass in the fibula here as well. So likely going to be a polyostotic fibrous dysplasia. And again, you're not going to get a biopsy that looks like this. You're going to get a resection, which hopefully doesn't happen. But you can see this fibrous tissue with this metaplastic, irregular bone within it. So it's fibrous dysplasia. Last slide for me is just a little bit about fibrous dysplasia. So, despite having all that osteoid, it weakens the bone. So the bone is very weak, and it's subjected to kind of forces of stress causing deformity. And this is one of the classic deformities associated with fibrous dysplasia, and that's a shepherd's crook. So that's the end. We didn't leave too much time for questions. I think I have 2 minutes.
I think we have a little bit of time for questions.
Okay. So we'll entertain some questions.
Lovely review.
Thank you.
I'm sorry, really, that you didn't get a bigger audience because it was worthwhile.
Oh, okay.
My question has nothing to do with anything you presented,
good.
but is important anyway, I think. So if an interventional radiologist uses ultrasound to biopsy a bone lesion, they end up getting paid so much more than the pathologist who doesn't, maybe, because you just get the tissue. If you do the ultrasound, can you bill?
You answer that, yes.
Yeah, so there's CPT codes for ultrasounds, and when we do the procedure, we bill as well.
Yeah, I know there are,
Yeah.
but my question goes around the question is, if a person who isn't a radiologist bills for it, you can still collect.
Oh, yeah. We've been doing it for over 10 years, and I think
Wow.
there's a number of other institutions who do ultrasound-guided FNAs,
I
and
think
I've
we
not
should
heard
get,
that we've had an issue with billing. I mean, you have to document, there's certain requirements for, the report and the imaging, but we've not had an issue collecting the bill for the ultrasound-guided biopsies performed by a pathologist.
Okay.
All right. Well, thank you all for coming out this afternoon, and don't forget to complete your course evaluations so that we can get the feedback for future meetings.